As an ICU practitioner myself, I can empathize with the narrative I am about to convey to you. The pandemic represented a profoundly challenging period for those of us in nursing, particularly those of us who worked in intensive care. We witnessed the most severe cases. Typically, individuals who contracted the virus but were stable remained in different wards. Those who were transferred to us were in a grave state. Consequently, we faced significant difficulties. The other wards observed their patients improving and being discharged, but for us in the ICU, we were commonly the ones preparing our patients for their final journey. I ask that you hear this account and attempt to understand our perspective. I appreciate your attention and hope you find the narrative engaging. I do wish that, at the time, our nation could have united to confront the pandemic. In the year 2020, I recall the initial outbreak. The Chinese authorities issued a global alert around December of 2019, as I recollect. During that period, I understand China had already initiated a lockdown, and we in the United States were primarily focused on the civil liberties of the individuals there. A number of us even circulated humorous content regarding the coronavirus across social media platforms. Subsequently, in March of 2020, the United States implemented shutdowns and lockdowns. I am an intensive care nurse practitioner on the nocturnal schedule. My working hours commence at 7 p.m. and conclude at 7:30 a.m., which typically means I encounter considerable congestion both en route to my workplace and on my return. Nevertheless, once the restrictions were enforced, there was a notable absence of vehicles, even on major thoroughfares. The atmosphere was unsettling, reminiscent of a scene from a dystopian film. It felt surreal. I have acquaintances employed in the emergency department, and others in different sections. Activity decelerated because individuals were apprehensive about visiting the medical facility. The alternate units were not occupied. In fact, their patient count was quite diminished. In contrast, within the ICU, we were receiving the most acutely ill patients. Our section began to accumulate individuals who experienced respiratory distress and needed mechanical ventilation. The diagnostic assays we administered at the pandemic's onset appeared to yield variable results. There were individuals exhibiting all the characteristic indicators, yet their tests returned negative. At that point, it was obligatory for us to utilize a standard face covering when attending to patients who did not have the virus, but we were mandated to don an N95 respirator when caring for those confirmed to be infected. One evening, a patient was urgently transferred from the ED to our level. He was a clergyman, likely offering prayers for numerous individuals and surrounded by his devoted congregation when he became infected. Upon his arrival on our floor, his cardiac rhythm was in the 30s. I was certain he would experience cardiac arrest, as we were unable to obtain an oxygen saturation reading. His extremities were cold. After we moved him into the designated room and onto the fresh bed, his heart ceased functioning. My colleague, Mel, who was only wearing a standard mask, was the first to initiate cardiac compressions. We remained uncertain whether the individual was carrying the virus. Mel prioritized the patient's well-being over his personal safety. Whenever a patient requires chest compressions, Mel is always the first to intervene. Performing compressions necessitates close proximity to the patient's facial area, thus elevating the likelihood of viral transmission. Following a quarter hour of resuscitation efforts, we managed to achieve a restoration of spontaneous circulation. I was assigned to care for this patient. His condition was precarious, necessitating constant, individualized attention. Throughout that night, as I attended to him, he underwent multiple episodes of cardiac arrest due to his heart rate plummeting to critically low levels. I was compelled to remain at his bedside, continuously administering pharmaceutical interventions to elevate his heart rate. The subsequent evening, Mel served as our resource nurse. He had no specific patient assignment, so he circulated, providing assistance to colleagues and covering their respite periods. My patient was connected to a ventilator and relatively hemodynamically stable at the commencement of my shift. Nonetheless, I had to repeatedly enter his room due to his cardiac rhythm descending into the 30s. I was required to physically stimulate him to rouse him and administer medications to sustain his heart rate. Each instance I donned protective attire to enter the room to aid my patient. My fellow workers remained outside, prepared to equip themselves if I required assistance, but upon stabilizing the patient, I would provide a gesture of assurance, indicating I had the situation managed. We were so low in mask, gown, and face protection that we had to use them wisely. If we didn't need all staff to wear them, we have conserved the equipment for other critical moments. At approximately 2 a.m., Mel arrived to facilitate my break. I departed to consume a meal in the staff lounge for a half hour. Upon my return to the unit and resumption of my duties, I peered into my patient's chamber and observed Mel within. He was fully attired in protective gear, monitoring the patient. I gestured with a thumbs up to inquire if the situation was satisfactory, and he reciprocated the gesture. I deduced that he did not require my intervention, so I positioned myself at the nursing station and accessed my patient's electronic record to review any updated physician directives or forthcoming pharmacological administrations. Abruptly, I noticed Mel exiting room 4. I was momentarily stunned. I had just witnessed him in my patient's room. Startled, I inquired whether he had indeed been in my patient's vicinity, and he responded negatively. He had been assisting a coworker with the hygiene of a different patient. I maneuvered away from the workstation to re-examine my patient's location. There was no one present apart from my patient. A sensation of unease coursed through me. I resumed my position, fixated on the computer display. After cleansing his hands, Mel took a seat adjacent to me and indicated that he was experiencing malaise. I reviewed my patient's records and noted that his viral laboratory analyses had finally been processed. The findings confirmed that my patient was, in fact, positive for the virus. I shared this information with Mel, reminding him that he had been the initial responder to perform chest compressions on the patient while only wearing a standard face mask. I advised him that, given his unwell state, he should undergo testing and return home. Mel expressed reluctance to depart due to the necessity of a resource nurse, but my colleagues and I were insistent. If we failed to prioritize our own well-being, there would be no one remaining to provide care for the patients. After an hour, Mel eventually acquiesced, underwent testing, and departed for home. My patient ultimately succumbed a few days later. I vividly recall a colleague entering the room to assist me in cleansing, labeling, and securing the deceased. It was a distressing experience. Upon disconnecting him from the ventilator and repositioning him for placement in the body bag, bodily fluids emanated from his nasal and oral passages, already emitting an odor of putrefaction. It was unknown how long these fluids had been retained within his system. During the initial surge of the virus, the affected individuals were so critically ill that they remained on ventilatory support for 1 to 2 weeks before expiring. It was an extended, arduous struggle that typically culminated in mortality. Family members were prohibited from being present at the bedside, so we were the only individuals with them during their most challenging moments. Certain relatives requested virtual communication with their loved ones while they were connected to ventilators. That was the extent of our ability to provide support. It was profoundly sorrowful and emotionally taxing for all of us nursing staff. The subsequent week, we received Mel as a patient from the ED. He was transferred to our unit on a ventilator, already under sedation. He had presumptively contracted the virus while executing chest compressions on the aforementioned patient while wearing only a standard mask, as opposed to an N95. For those who harbor skepticism regarding the efficacy of masks, they are indeed effective, particularly N95 respirators. Within the healthcare setting, we undergo annual assessments to ensure proper N95 fit. During the evaluation, a bitter aerosol is dispersed into the surrounding environment. If we perceive the olfactory or gustatory sensation of bitterness, it signifies that the N95 respirator we are wearing is not an appropriate fit, whereas the absence of detection indicates a correct fit. Regrettably, the majority of individuals outside the medical profession do not possess adequately fitted masks. Mel was situated in the identical room where my prior patient had passed away. It evoked memories of that unsettling evening when I believed I had observed him at the bedside when, in reality, no one was present. Contemplating it continues to induce a sense of trepidation, but more significantly, witnessing Mel in this state instilled profound fear. Observing him on a ventilator was akin to envisioning myself in a similar predicament. Mel was classified as obese and diabetic, with pre-existing medical conditions that placed him at elevated risk for severe complications. I was deeply saddened. He was a compassionate individual who consistently prioritized the needs of others over his own. Diagnostic imaging, including thoracic radiographs and scans, revealed the presence of multiple pulmonary emboli in Mel's lungs. The virus induced a hypercoagulable state. We were compelled to administer potent anticoagulants, but these pharmacological agents carried the inherent risk of significant hemorrhage. Ultimately, the bleeding reached a perilous threshold, necessitating the discontinuation of anticoagulation therapy. It was a dire circumstance. He faced the prospect of mortality either from the thromboembolic events or from internal bleeding. During one of my shifts, I inquired of the attending physician whether Mel could be considered a potential candidate for pulmonary transplantation, given his relatively young age, in his mid to late 40s. The physician informed me that Mel was ineligible, not solely due to the pulmonary emboli, but because they were disseminated throughout his body. Even if we provided him with a new lung, it would merely develop additional clots. My spirits plummeted. I desired to implement all feasible measures to preserve the life of my coworker, my companion. Despite our concerted efforts, Mel ultimately passed away in our unit. We experienced profound sorrow for his family. His spouse and offspring were overwhelmed with grief. Our unit collaborated to identify avenues of support for them. We initiated a fundraising campaign, and for a fortnight, we provided evening meals to Mel's family to alleviate their burden. At the pandemic's inception, when the virus remained largely enigmatic, all members of my unit were apprehensive. We implemented all conceivable precautions to safeguard our families. Upon returning home, I would cleanse myself outdoors with a garden hose prior to entering my residence. I even donned a face covering when interacting with my young children, as I was uncertain whether I might be harboring the virus. In retrospect, I find some of our actions amusing, but at the time, we were simply striving to ensure the safety of all individuals. Subsequently, the Delta variant emerged, representing the most lethal wave I had ever encountered. I had never before witnessed such a magnitude of mortality. During that somber period, I do not recall observing any survivors following the initiation of mechanical ventilation. Those who were successfully weaned from the ventilator frequently required re-intubation. If they declined to resume ventilatory support, they would ultimately succumb. Some individuals underwent tracheostomy procedures, involving the insertion of a cannula into the trachea to facilitate respiration, but even this intervention proved insufficient. The majority of these patients necessitated exceedingly high ventilator settings, which resulted in ventilator-induced pulmonary injury. We felt a sense of profound helplessness. It was analogous to engaging in an insurmountable struggle that we were destined to lose. There was a preponderance of unfortunate outcomes compared to optimistic ones. If we refrained from placing a patient on a ventilator when they were experiencing respiratory failure, they would inevitably expire, but if we did initiate ventilatory support, they were highly unlikely to survive. It was an emotionally overwhelming experience for many of us on the front lines. During our most challenging periods, numerous individuals sought psychological counseling to manage their distress. A significant number of nurses resigned from their positions when their presence was most crucial. We were severely understaffed, striving to provide care for some of the most critically ill patients we had ever encountered. Then, one day, a 38-year-old male was admitted while receiving BiPAP therapy. He was experiencing extreme dyspnea, to the extent that even consuming a small amount of water exacerbated his condition. His agitation and apprehension further compounded the situation. The more he succumbed to panic, the greater his physiological oxygen demand. A significant portion of our efforts was directed toward maintaining his composure. Let us refer to him as Josh, as I prefer to maintain his anonymity. Josh was so agitated that we had a ventilator readily available at his bedside in case of necessity. I remained with him and calmly articulated, "Listen, I desire to provide you with the utmost assistance, as I wish to avoid placing you on a ventilator. That is the least desirable outcome. I do not want you to require mechanical ventilation because I have witnessed too many individuals who never recover. Please endeavor to remain calm and breathe. That is all I require of you." Josh attained a state of tranquility, but his spouse repeatedly contacted him via telephone and video calls, attempting to engage in conversation. Each time he spoke, his oxygen saturation levels decreased. I was compelled to instruct her to reduce the frequency of her calls. I needed Josh to concentrate on his respiratory efforts. Her retort was, "Oh, I comprehend your intentions. You are attempting to terminate my husband's life." I acknowledged that individuals were experiencing fear, but family members presented additional challenges to our duties during those periods. Ultimately, Josh's respiratory status deteriorated despite receiving maximal support from the BiPAP apparatus. His oxygen saturation barely attained 88%. He was of a young age, and we sought to avoid endotracheal intubation, but we were presented with no alternative. We could either await his physiological collapse, or we could proactively intubate him. The physician made the determination to initiate mechanical ventilation. As we administered sedation, I observed tears streaming down his face. A few days subsequently, Josh exhibited favorable progress. Instead of escalating his ventilatory support, we were able to reduce it, an encouraging indicator. However, he subsequently developed a thrombus in his right hand. His index and middle digits were not receiving adequate oxygenation, and despite aggressive anticoagulant therapy, the tissue underwent necrosis. His digits assumed a black, necrotic appearance. Following 4 days, Josh was successfully liberated from the ventilator and transitioned back to supplemental oxygen. He was among the fortunate few, but he was deeply distressed regarding his digits, cognizant that they would necessitate surgical amputation. Josh was the sole individual during the Delta surge who was successfully weaned from the ventilator in a stable condition, albeit with the loss of 2 digits. All other individuals either expired while on ventilatory support or were briefly extubated, only to experience subsequent deterioration and decline reintubation, ultimately succumbing. The Delta variant did not result in gradual mortality, as observed with the initial wave. The initial wave manifested a 1 to 2 week course prior to mortality. Delta induced death within a matter of days. I had never encountered such extensive loss of life. I relinquished my career in healthcare entirely following the pandemic. It exacted a significant toll on my psychological and physiological well-being. I continue to receive therapeutic interventions, indeed, many of us still do. At the pandemic's onset, we, the frontline workers, were perceived as heroic figures, but as time progressed, public perception of us shifted. When I venture into public spaces or engage in shopping, the mere act of donning a face covering may elicit offense from certain individuals. They are unaware whether I am endeavoring to protect myself or them, perhaps due to a respiratory ailment. If you are acquainted with someone who served in the healthcare profession during the pandemic, I implore you to extend kindness towards them. On occasion, simply inquire about their well-being, or whether they require any assistance. A considerable number of us have experienced the loss of companions and colleagues to this virus. I express my gratitude for your attentiveness to my account. That concludes this presentation. I appreciate your continued engagement and support of my narratives. May you have a pleasant day or evening.